the Gulf region and the Middle East. And good morning for Dr. Deborah from Texas. We're happy to share with you the telehealth and COVID-19 and cancer patients, or teleoncology services that we, as we are in the era of the COVID-19, and we're still there. So we need to cope with the disease the way that suits us and suits our patients. I'm Dr. Riyad. I'm a clinician, a medical oncologist by training and by experience, cancer researcher as well. I'd like to introduce the panel today. Dr. Deborah, a medical oncologist from Texas, Point Cancer Center. Dr. Maria Madar from Abu Dhabi, from Cancer Genetic Center. Am I right, Dr. Maria?
Yes, yeah. Yes.
And,
from UAE Genetic Disease and Sheikh Zayed Research Center.
Thank you very much, Dr. Maria. I'm really sorry for the, and my dear friend, Dr. Sausan Madi from Friends of Cancer Patient Society. And we have Mr. Usama Al-Hassan from the DHA. Am I right, Usama? Usama, do you hear me? Anyway, we're gonna start for the sake of time. We have 1 hour to speak and to discuss more about the subject that telehealth, oncology health, or teleoncology service within this pandemic. In general, as we all know, in general population, the symptoms, the vast majority of COVID-19 forms are mild to moderate with mild respiratory symptoms. But however, when we speak about patients who are immune compromised or with underlying comorbidities like cancer patients, then we're talking about more serious complications by coming to the hospitals, including pneumonia, high risk of hospitalization, respiratory failure. It may into multiple organ failure. That's what we faced right now. And unfortunately, bad sequels. Of course, we have challenges. The pros and cons. We have challenges. One of these challenges, Dr. Deborah will speak more about this, but one of these challenges, at least we are facing the technology itself, how to use this technology when it comes to distant consultation. The concern not in the UAE, but of course in the other regions, of course the more the grows bigger, the concern grows with bigger and bigger with the poorer patients with limited access to internet. Again, it's between, I would say, between the threat and the opportunity. Threat of giving the cancer patients under care by distant consultation, by telehealth, and the opportunity to maybe to reduce the infection and to reduce the cost of coming to the hospital. And then we'll move to a new era of technology and in dealing with cancer patients at least. So we'll come to, I'm just wrapping up now, just to come to all this, we'll try to discuss. So if there is any questions, we'll be happy to receive at the end of the panel's whatever comments. I will give the floor now to Dr. Deborah from Texas to speak about the subject, and then we'll come back again. Dr. Deborah, please, the floor is yours.
Thank you, Dr. Bendodef, and thank you for having me today. It's a pleasure. It's a pleasure to join you all from across the world, and especially a pleasure to see females that are involved in telemedicine. I need Svetlana to allow me to share my screen to go through. So Svetlana, if you can allow me to share my screen. It says the host disabled participant screen sharing. So Svetlana, I need for you to go to the bottom and permit me to share my screen. While she is doing that, I'll tell you that, so Svetlana, in order for me to show my slides, I need for you to permit me to share my screen. So I'll tell you briefly that I'm a vice president of Texas Oncology. So we are a large private cancer practice in the state of Texas, which Texas has about 30 million people. And in Texas, we see about 60,000 new cancer patients per year in my practice, to our total 124,000 cancer patients per year. So we're a large practice. We have 221 sites of service, 500 doctors, and about 150 advanced practice providers. And it looks like I can't share my screen, so I'm just going to talk to you about what we've done. So I'll say that there are really two things that I've channeled as we've entered into telemedicine. And while we've done telemedicine for 5 years, we were really limited by some of the policies to see what we could legally do in terms of where patients could receive care and how we could deliver it. So it's really grown tremendously in the last 2.5 months. And just to give you some scope of that, we've grown to about 45,000 telemedicine visits in the last 2 months. It represents about how we see about 1/3 of our new cancer patients and about 1/3 of our established patients. So I'm going to talk to you about some of the policy changes that we saw. I'm not sure if that correlates to what's in the Middle East or not. Why it's important, how we onboarded, because it's not just about the clinician. Why we are using the VC platform, which we use. What it looks like for the patients and clinician, how we market it to get it out, information out to our referring providers. Billing and compliance, the revenue cycle management. I'm sure you have that there too, that you have to get paid for what you do. And then looking at utilization. So I'll say in the United States, while there are many things that we didn't do optimally with regards to coronavirus, we did have very progressive telemedicine policy. And that really resulted in 3 separate federal statutes that were also partnered with state statutes that permitted doctors to deliver patients' care at their home or at any site of service, for doctors to deliver care at any site of service, for it to get paid for, and then actually expanded telemedicine permissions not only to HIPAA compliant platforms, but also to platforms that were private but not HIPAA compliant. So for us, initially in March, when we onboarded 500 doctors, it was to keep coronavirus patients out of the clinic. Being cancer practitioners, and I'm a breast cancer specialist here in Austin, we have the most vulnerable patients. We know that the mortality with cancer patients is anywhere from 3-fold to 6-fold in comparison to an average patient. And so we had to dramatically reduce risks in clinic. Svetlana is asking me to send this to her. Let me just do that quickly. So we had to dramatically reduce risks, and that's been really useful. I have seen coronavirus patients by telemedicine and had them stay at home. So that means I don't expose them to my other patients in clinic. I don't expose my staff, and I also don't have to send those patients to the hospital. So that's been incredibly useful for our patients. Also, we want to see new and established patients, because established patients need to continue to get care. And we're obviously in an altered place for the next several months. And new patients need to be evaluated, but some of them are fearful of coming to the clinic. So there are multiple different use cases for telemedicine. While initially many of us adopted it to try to make sure that we could care for acute care patients like coronavirus patients without bringing them into the clinic, it's also been useful because we've had to implement policies to reduce visitors in the clinic. So that way new patients are able to have their family members present because we're using a telemedicine platform. We've been able to do consultations in the hospital using telemedicine. We've been able to discuss advanced care planning for patients that are dying of cancer through telemedicine. We've been able to do radiation therapy visits, genetics consultations, by telemedicine, which I think it should never be done another way. Telemedicine is a perfect way to do a genetics consultation. We're now using it for telepharmacy services and for surgical follow-up. So really every use case, maybe except for gynecologic oncology, that's a little bit harder on telemedicine. But everything else, I've even diagnosed new patients with inflammatory breast cancer on telemedicine. And so while my exam is more limited, it's still useful. So this has been really important for a number of reasons. Not only did we want to keep coronavirus patients out of the clinic, but we also had to alter our clinic structure. we had to dramatically reduce the volumes in our clinic in order to permit social distancing. Good, perfect. So, oh good, can I advance myself? Oh good. So these are the two things I would channel with telemedicine. One, Voltaire, not to let the perfect be the enemy of the good, because it's all a little clunky when we start our operations for the first time. And the second, that change is the only constant, that with new CDC guidelines and changing community prevalence of coronavirus, we've all been constantly in flux, which is unusual for us. So again, this is sort of what I'll go through today. And you can go to the next slide. These are the different policies that have been useful in the United States, but obviously different for you. Next slide. Next slide. So this is just a diagram of different ways it's been useful. We've used it in the clinic, in the hospital. We've used it for palliative care visits, for genetic consultations, for radiation oncology, critical care visits, and telepharmacy. And actually this week we started using it for support groups, because our patients feel very anxious and helpless during this time. And that's been incredibly useful for our social workers to manage support groups. Next slide. So this just shows that our clinic structure physically has changed. We're not letting visitors in the clinic, and we have physically taken chairs out of our waiting room to reduce our capacity to try to make it a safer place to permit social distancing. Next slide. So what has changed is that we are not permitting visitors, that we have staggered staffing because many of our staff are working from home, that we go from wearing professional attire to scrubs, masks, and gloves in our clinic, that we usually have close personal contact. You know, I'm a breast cancer doctor. I treat women mostly. You know, I touch them, I hug my patients. I don't do that at the moment. And that usually when our office triages patients, when our nurse triages patients and they might bring them into the clinic, they're now triaging them to telemedicine. What we are trying to keep the same is we don't want to just send patients to the hospital, because the hospital might be the largest concentration of coronavirus in the city, in the community. And most of those patients, after they're evaluated in the hospital, even if they don't have coronavirus, they're going to be back in our clinic the next week. And so for many reasons, we want to keep our patients out of the hospital. Next slide. So we grew gradually. So I'll say in February, we onboarded about 15% of clinicians for the hopes of onboarding for acute care visits. And then in March, about 80% of our physicians had onboarded. We really saw acute care established in new consultations. In phase 3 in April, we really had established most of our clinicians, all 500 of our doctors and 150 of our advanced practice providers. And this was through a series of training webinars. And in phase 4, we really had all of our support staff, like our medical assistants and our schedulers, onboarded with the platform so they could teach patients how to get on the platform and be able to do their normal functions of performing a review of systems, vital signs, confirming of pharmacy, medications, and referring providers. And that's been really helpful. So all in all, it's about 650 clinicians and 900 support staff that have been onboarded on this platform since we began at the end of February. Next slide. So as I mentioned, it's a multifactorial process, or as I like to say, a multifaceted gem. It's not just the doctor. We're not the holy grail of the patient experience. So I've literally done over 30 webinars training different sets of individuals, not only our clinicians, but also our IT staff. So at each of our 221 sites of service, there's someone to fix speakers and video cameras. Svetlana could use that today. But that way we have boots on the ground, or people to fix those problems whenever they happen at the cancer center, because it's not reasonable to do that remotely. We also trained our practice administrators and practice directors, because they need to manage our schedule and they need to be communicating with doctors about which follow-up patients can move over to telemedicine on the schedule. We need to communicate with our schedulers and our medical assistants, because they're the ones who set appointments, build them in our practice management system. And that's been important to get us paid, because when we look at revenue cycle management, there's these test edits that occur to make sure that the billing goes out with a clean claim, so claims get paid. Similarly, the medical assistants had to be onboarded, because they need to be able to talk to a patient and bring them into a room review their medications, pharmacy, referring providers, review of systems. And that way it makes my job easier because then the patient is available to be seen. We also had to get our marketing team on board because patients needed to know that we were doing this and referring providers needed to know that we were doing this. So they developed a site on our landing page. So you can see that's here. This is on our landing page, and you can see that there's ways to request a consultation and how to download the instructions. Now we have both videos and PDFs there. We trained our liaisons. That's who goes out to our referring providers so they would know how to refer patients. Coordinated this with our internal legal counsel because that's always important for everything we do. And then everything in coordination with revenue cycle management, because at the end of the day, we want to make sure that we're compliant in a way that we'll be able to be paid for the services that we render. Next slide. So there are many different platforms that we've been able to use, though we prefer VC for a number of reasons. I will say, and I think that Dr. Mahdi mentioned this, that sometimes the broadband access can be variable. And I'll say in the state of Texas, there are some places like Austin and Dallas and Houston that have more than 99% broadband access. And VC is an optimal solution, and it's always our preferred solution. But there are some places like in Texas, in Longview or in Amarillo, that don't have broadband access to the same degree. And in those situations, VC has been a little bit more challenging, and sometimes people have used other platforms. So this is sort of a spectrum of platforms that people are using, though we overwhelmingly prefer VC, and that's comprised over 95% of our visits. Next slide. When you think about why it is we prefer that, it's because it gives patients a branded experience. We believe it's high quality. The VC team, who you all probably know, Milton, they have tremendous service. It's very physician specific in terms of the virtual waiting room. There's an embedded consent, so patients can consent very easily. We know there's security and compliance. It's an efficient process. And if you have broadband, the bandwidth is not an issue. Also, it's very easy to satisfy the needs for compliance, for revenue cycle to get compensated, and also for legal. So it is strongly our preferred platform. Next slide. So as I mentioned, we've had some limitations. This just shows our onboarding, how quickly we onboarded. Next slide. So this is what it looks like for the patient. They can use either their smartphone or a computer. You can see that patients use the VC Clinic application and we use the VC Messenger application. They get a text. I prefer to invite them by phone, by SMS, because then it's about a 2-minute turnaround between the time they're available to the visit, but it's relatively easy for them to use if they've downloaded the app. Next slide. And you can see that patients enter my virtual waiting room. So it's branded as Texas Oncology. This is a logo that they're familiar with. They know that they're not getting a random text from a spam or something. You know, it's a familiar site and it's relatively easy for them to enter. Next slide. Our doctors also have branded waiting rooms. So this is the Texas Oncology Virtual Clinic. This is my colleague and it's his virtual waiting room. Next slide. So you can see that it's relatively easy to invite patients. And again, my patients can see that this is me and it has information on me just like it does on my web page for Texas Oncology. And so they know that this is not a joke, it's not a scam, this is their doctor. Next slide. We invite patients by SMS and it's relatively easy. You send them an invitation. Now my medical assistant is doing the inviting and that's strongly preferable. But even I can invite patients and that goes relatively seamlessly. Next slide. You can see that this is the patient view. You can share files and drag and drop. Patients like that because particularly in oncology, they like to look at their scans. They like to see their MRI results, their lab results. They like to trend their tumor markers. And so all of that is very easy to share with them. If it's on my screen, it's easy to share. And using the VC Messenger application is better than just using the web interface. When you're done, you just check out the patient. So again, there are multiple use cases. You can go to the next slide. We sort of talked about those already. We can do it from the office in the hospital. I've also used it on call in the evenings for patients I would have otherwise sent to the emergency room, but I've been able to evaluate them in a meaningful way using the telemedicine platform. And so I've not had to send them to the hospital. I've been able to manage them, prescribe them antibiotics, and see them in the clinic the next day. So it's much better for them. Next slide. So again, our marketing team has been really important because we've developed some landing pages on the website with patient instructions. So you have to set expectations and make this easy for patients. Next slide. And now we're doing virtual support groups. So our social workers are doing this, which has been amazing. Next slide. So you can see that this is the patient information that's available on our website. So we have both videos and a PDF that shows how patients, how we do this to try to make it easier for them. You know, being a cancer practice, many of our patients are older. Next slide. This is probably not as pertinent to you. This is billing approved telehealth codes. I don't know if you use the same codes, but these are Medicare allowable CPT codes that we use. Next slide. It's important to have clear ways that you bill. Next slide. Go to the next slide. Next slide, sorry. So if you look at telemedicine, you can see that these are our established patients. So this represents, the green box is, this is the weekly average, December, March, April, the weeks in April and May. And this is from last week. So you can see that it's about 1/3 of our patients for established patients. Next slide. And these are new patients. So you can see that it's about 20 to 30% of our new patient visits in terms of volume every week. So these are weekly totals for our statewide practice. Next slide. And that's really all I wanted to talk about with regards to how we're using telemedicine today.
All right. Thank you, Dr. Deborah. I was really, do you hear me?
Yes.
Yeah, I was really amazed with your experience and with the whatever oncology and teleservices at the Texas at your center in Texas. I think before we start the discussion, I would go for Dr. Mariam. I think he has something to say.
Yes,
I give the time for you and then for Dr. Sousan later.
Yes, thank you very much, Dr. Riyad. Thank you very much. Thank you, Dr. Deborah, and well done. We are so happy with all the success on the level of service care for the patient. And allow me to speak on the behalf of the community also of oncology, as well as from a patient point of view, as well as from a service providers. It happened that I'm so lucky to be among a group, especially on WhatsApp. You know how the technology works nowadays. We have a very repetitive group in WhatsApp where it's led by well-known oncologist in United Arab Emirates. And the good part of it, what I heard from you, Dr. Deborah, it's almost similar to what is going on with our colleague here in United Arab Emirates. And specifically, I'll talk about 3 main centers in United Arab Emirates where we maintain as much as possible a good quality of services and lifestyle for our patient when it's come to service or even the post-treatment care and prevention tool. And from a patient point of view, before this session, yesterday and today, I had a very healthy discussion with many of those patients who were going through this pandemic while they are either on treatment or they are on follow-up. And from their feedback, they are so happy and satisfied so far. And you know that you cannot satisfy 100% of your customer, but they were so happy with the service which is provided. And a very nice comment I received from one of the patients where she said, Miriam, during this pandemic, it is the only time where I had more than 1 hour with my physician without any interruption, neither from a nurse or any other reason. And that itself can tell you how much the good and the positive side of the whole situation. Sometimes we need to see the full part of the cup. So when we talk about telemedicine, and specifically in United Arab Emirates and oncology, it's really valuable to mention as well, as you know, that in United Arab Emirates for the past 6 years, we are trying to be involved constructively in clinical research when it's come to any type of new pharmaceutical company. And as you know, now there is a new terminology which says cancer is a disease of DNA. So when we talk about the DNA now, even the medication which we choose for our patient, it goes beyond the specification of the symptoms and signs. We reach to that particular part of their DNA to select the relative medication related to their ethnicity or whatever. So when we talk about this part, little bit we had not a good effect from this pandemic, because majority of those research are on hold, majority of them, if not all. Specifically when it comes to pharmaceutical company, when it's come to communication with the patient, many other sites. And we as a physician, as well as molecular biologists, and from a patient point of view, we feel this is little bit affected us a lot. And telemedicine was not there to save us in this part. And I believe that was a great opportunity for our colleagues who are helping us to use this tool in a good way, to be a discussion for their future improvement of such needs when it's come to oncology. And the point again, I'm talking from a local point of view. The good part of the telemedicine or oncology specifically in the past 3 months was related to data analysis and communication between physician and radiologists and all those discipline team in treatment of cancer was very effective. And even majority of our colleagues, they said we had longer time to sit and discuss with no interruption again. And the time was very fruitful when it's come to a discussion. And as you know, now it's more than 10 years in United Arab Emirates, we started to have the trend of teleconferences, and that was started in economic and some business gathering, but it extended its hand to the medical field. So that was really improved dramatically when it's come to pandemic. And without the telemedicine, I think we won't be able to reach this level of satisfaction when it's come to service provider over the cancer patient. The final point where again, I will try to be very, I'll try to summarize what I received from a colleague and some of the patient as well. Again, it's related to post-care and preventive care for those patients. Some of them, they were not happy because many of those appointments and routine checkup were postponed. But again, with a good assurance from the physician that will not affect the course of the disease or the course of the treatment, some of them, they were a little bit calm. But again, that was another issue where we were facing it, but with their understanding that they are one of the highest risk group when it's come to COVID-19 and infectious stated here. The final point is related to bioinformation. And as you know, when it comes to genetics, when it comes to research and to come in oncology, we believe and we saw it and we agree majority on the team when it's come to the research and oncology, that this was the only time ever, according to a very senior physician who is around 69 years old from India. He said, Miriam, this is the only time since I was enrolled in healthcare services where I can see a very transparent collective collaboration between all the global research center, where they share the point and the information immediately on site. Because majority of them, they used to keep those information, not because they don't want to share it, but they want to be the first who publicize that particular facts or finding. And that was little bit putting some boundaries between scientists and some healthcare provider. So in my opinion, pandemic, COVID-19 had a very good side, a very good impact in some areas related to oncology particularly, and it was affected in a very negative side, the non-communicable diseases like diabetes and hypertension, where majority of our patients are not on the priority of the list. And this is an input, a very brief input from some of the colleagues in this field in United Arab Emirates on the field of service provider, research, and patients.
Thank you, Dr. Mariam. Thank you. It was really a very nice, concise, comprehensive overview of starting from telemedicine or teleoncology to the DNA and molecular levels, and then to the research, and you touch everything as well, and we need to discuss it more maybe. We give the chance to Dr. Sausan Madi from Friends of Cancer Patients. Please, Dr. Sausan.
Thank you, Dr. Yal, and thank you, Dr. Pat, and thank you, Dr. Mariam. I think I'll start by introducing Friends of Cancer Patient because it sets the scene to what we do and how we are linking telemedicine to our work. So Friends of Cancer Patient is a UAE-based organization, and we are a charitable nonprofit organization that actually caters for cancer patients. And what we do as a number one priority is provide access for cancer patients, whatever that means. Most of the cancer patients that comes to us for help want financial access because cancer treatment is very expensive and they don't have health insurance to cover their treatment. So financial access is a very important mission of our organization, but also we provide psychological and emotional support to the patient and their families. Now, the other mission that we do, the other objective is also catering for the community, which we provide a lot of awareness campaign about screening program for early detection for cancer patients. And we worked very closely. I mean, we work very closely with Dr. Riyad, and even previously, historically, we worked with Dr. Mariam through UAE Genetics on numerous campaigns. Now, going back to telemedicine and what happened with the COVID-19 situation, part of the work of Friends of Cancer Patient is also we do a lot of advocacy when it comes to being the voice of cancer patients in the community with policymakers as well. And during the challenge that we started to see during the COVID-19 is that although, as my esteemed colleague Dr. Mariam mentioned, and Dr. Riyad also mentioned, telemedicine as an infrastructure in the United Arab Emirates has been there, because UAE has always been, a pioneer in all fields. So as an infrastructure, it has been there. But it hasn't been a priority to utilize because the hospitals were there, the doctors were there, the whole pathway of patient journey is there, and it's perfect, and it provides quality service as well. And you have even executive hospitals that provide really high quality service for patients. So it wasn't really utilized. It's only when we had the COVID-19, and I think it's the same scenario that happened in Texas, is that the utilization of the service just, I don't know how much it doubled or tripled or quadrupled, but it happened as well overnight here. Now, the challenge that was faced by some of the patients, and again, as an organization, we do voice the challenges, and I do understand that we have some of our beneficiaries also joining this panel. Maybe they can give some of their challenges as well. One of the major disparity was insurance didn't catch up to the service provided. So there was lots of hospitals who hesitated to introduce the service, although they had the infrastructure, because they did not actually know how to link it to the revenue cycle, which actually was mentioned by Dr. Pat before in her presentation. Now, hospitals knew, but the insurance was really delayed into catching up to what was going on. I remember as a service utilizer, we have insurance as employee. I remember we only got a circulation from our insurance company only 2 weeks ago or 3 weeks ago, that this is how you can utilize telemedicine, and it is actually covered by your insurance company. I mean, I did not know if my insurance company do cover telemedicine or not. And that will apply to many people. So I think this is one of the challenges, that the robust system, the policy change that need to happen, that it has to be as fast as what is happening. So I think the insurance company really lagged behind when it came to matching the service provided by the hospital to the actually, okay, will this be paid by me, is self-pay, or the insurance will have to pay it. Now, the other challenge that I think many patients face is also being technology or IT literate. I mean, we were just discussing today over our team meeting, which we have virtually every day in Friends of Cancer Patients, that Some of the patients, we try to communicate with them. I mean, they only have a mobile phone, and they really, although everybody, all Earth population is on WhatsApp right now, some of them actually don't have WhatsApp, and they only use the phone for the sake of phone. So yes, they know how to use the phone, but they don't have that savviness into downloading an app. So it's a minor population of the patient, but still that would be one of the challenges as well. Now, the other thing that maybe was a challenge for us as a service provider, we are a charity that provides services for cancer patients. So we had to shift, I think it took us around 2 weeks to shift all our operation virtually. And we had to shift all our, how to apply for the support. All this now is online, it's virtually, it's great, the system is working perfectly. But I think one of the success stories that I would like to share, and I think it was also mentioned, which I was very happy when I heard it in Dr. Pat's presentation, was the fact that even support groups are now going virtual. And that's great, because that's exactly what we have been doing now for the past 3 months since we gone off, since we started the lockdown, and we started to work virtually from and remote working from distance. So our beneficiary department, we don't call them patient department, we call them beneficiary department in our organization, have shifted completely. They have not stopped the psychological and emotional support, because we think that if anything, under the current circumstances, it is needed even more. Because as you know, and as Dr. Riyadh would also agree, and my esteemed colleague would agree, is that we will be facing a lot of mental health issues problem post the COVID-19 era. Even if we're now going to be easing the lockdown and we're going back to work and we're going back to, life normal, whatever normal that will be, I think there will be a lot of mental health issues that we need to, start tackling. And this is where I think Friends of Cancer Patients worked very hard to make sure that the connectivity, the one-on-one connectivity with the patients and with their family, is even more stronger. We had lots of sessions, support group sessions online. We did a lot of Zoom meetings as well online. We tried to utilize, we just finished our holy month of Ramadan, which is a very spiritual month for us. And we try to utilize that spirituality as well with the patient. We ask the patient to create a video diary of how they are, enjoying their day in Ramadan, how they are connecting spiritually, and I think that helped a lot. So definitely, telemedicine or virtual technology, when it comes to connecting with the patient, is definitely helpful. And again, we're all talking the same thing. The technology is there. I think COVID-19 only acted as an accelerator for us to use the technology. And I think the question is now, today, what is the future now? Are we going to continue with the same path? What is the path after COVID-19? Are we continue using telemedicine? If yes, how would that look like? Then what will happen to the hospitals? I think these are the questions that I'm excited to look into and see what the future is going to hold. And thank you very much, Dr. Riyadh.
Thank you very much, Dr. Sousan. As usual, very valuable points, comprehensive, whatever overview. Again, from technology part back to the patient side, Dr. Pat, and I would see, as Dr. Sousan just said, and Dr. Mariam, we have all the technologies here in the UAE, but again, we have some obstacles. One of these obstacles, maybe from the human mind, maybe from the patient side, from the physician side, as an practicing oncologist, I would have like maybe the main obstacle in selecting patients who are asked to come to my clinic to see me, or just to give them the consultation over the phone or by teleoncology. This will be the major obstacle, I would say, in selecting patient, the proper patient who you want to ask to come to your clinic immediately, or no, that's fine. You go with the follow-up over the phone or over the telecommunication.
Yes, so I've worked with my staff to try to identify patients, and I've picked patients that I think would be good for telemedicine. I've tried, it was my intent to have it be half of my clinic, but it's actually ended up 90% of my clinic is now telemedicine, because actually patients are preferring it, and so I tell my staff to contact the patient and give them the option. So they've been doing that, and patients right now prefer it because there's a lot of anxiety and fear, and so they're anxious about coming into the clinic. Now, with the platform that we use, because we use the VC platform, then my scheduler has to email them instructions about the app to download and make sure that they've downloaded the app. To Dr. Sowson's point, it can be sometimes in older patients that can be a technologic barrier, which is why we've put content on our website that shows a video and a PDF, so patients can see that. So that, takes some management, but we have them looking at my schedule 6 weeks out, because I think we're going to be like this for 6 more weeks. And that way they have some time to sort of get used to it. I will say the other thing that Dr. Sowson mentioned that I think is critical is the revenue cycle piece has been critical, getting paid for what you do. So, I don't know exactly what it's like there, but in the United States, we have public payers like Medicare and Medicaid, and then we have private payers, commercial insurance. And while there was very progressive Medicare policy, which is most of our cancer patients, in March from the administration, from states, the commercial payer policy has literally changed every single day. So that poses a challenge for a practitioner when you're trying to bill, because if you submit a bill and the payment policy changes, in order to resubmit the bill correctly, it costs us about an average of $16 every time we do that. It's quite costly to resubmit. And so what we have done to try to account for that, in addition to meeting with different payers to try to make sure that the coverage policy is favorable, is that we've held our claims. And so we held them for a few weeks. So when they go out, they can go out clean and won't have to be resubmitted later, because it costs us a great deal to do that. And so, it's been a particular thing that's been a little funny. It's been nobody's concern, because we're all concerned about serving patients and trying to make sure the patient experience is good and that our clinics remain safe. But at the end of the day, we do have to get paid for what we do. And so it's important to think about that revenue cycle piece. And our team has been really good about giving us up-to-date information. And I will say that the payer community in the United States has been very favorable. While many had approved telemedicine sort of preliminarily through May 31st or July 31st, many of them have come back now and reapproved for several months. So, we would like for them to continue that approval even after the pandemic goes away. But because I think it's really meaningful for patients, and there are some visits that are actually done much better. But that's a critical piece of it.
Yes, go ahead, Dr. Bat, we're listening.
The other thing that I wanted to mention is just the importance of physician training. This is a new forum for us to interact with patients, and it's important for physicians to undergo training from individuals that are familiar with this, so they can become familiar with it, and it's not a barrier for them. And then like Dr. Sowson said, there are all these other applications that are wonderful. So I love that our social workers throughout the state are doing virtual support groups. I think that's been incredibly meaningful. All of our patients have heightened anxiety and helplessness, and them doing support groups has been helpful. Another place that it's grown is telepharmacy. So that's been something we hadn't planned on, but now we're using to support patient care. And then we are using it, as we did before all of this, for virtual tumor boards, which has facilitated better collaboration between our clinicians. So, at 221 sites of service, we're all in different places. And so we have region-specific tumor boards. So I run our breast tumor board, and that way we're able to virtually collaborate with medical oncologists, surgeons, and radiation oncologists to make sure that care is delivered seamlessly.
Okay, excellent, excellent. Also, our experience here in the UAE, as I'm working as a clinician at the University Hospital Sharjah, we started since the beginning of this COVID-19 era. We started the teleconsultation and telepharmacies, but this services is provided for a subgroup of patients, of cancer patients, who are on follow-up and on oral whatever therapy, like hormonal treatment, for example, in case of breast cancer, or or supportive treatment. The point, Dr. Pat, that I want to ask, what about the other subgroups? If this is one group, patient on follow-up and on oral therapy, and grossly they have complete remission or in a remission, but what about the patients who are newly diagnosed, like the patient that you just said in you just mentioned in your presentation, that you diagnosed inflammatory breast cancer by teleconversation or telehealth? So
Yeah.
I think those subgroup, or this subgroup of patients with early diagnosis and new diagnosis, and our intent is curative intent, they need to come to the hospital.
Well, so Dr. Riyad, it's a great point that you make. And I'll say that there are better candidates for telemedicine than others. And so I think follow-up visits, to your point, patients on oral oncolytics, benign hematology patients, genetics risk consultations, advanced care planning consultations, care coordination visits, reviewing new treatments, surgical follow-ups. Those are great telemedicine visits. But I think that new patient visits can be telemedicine visits. So for example, the patient who I saw a few weeks ago with inflammatory breast cancer, by seeing her by telemedicine, I was able to see her right away. And then I was able to order all of her staging studies that she required. And then I ended up bringing her into my outpatient clinic the following week to initiate chemotherapy. And at that point in time, I was able to do a complete physical exam. So, you can sort of do what you can. Most patients, even though I'm a breast cancer specialist, most patients I see in follow-up, I don't do a breast exam on telemedicine. But you can, if you need to, at least visualize their breast to look for physical differences. And so then I just did a regular exam when she came in to initiate chemotherapy the following week. But it allowed us to expedite her care. And as I think about that, we should always do that. Last week, on Friday, I saw a new breast cancer patient who has a stage 2B breast cancer. And she's a young woman and wants to preserve her fertility, but will need chemotherapy. And so by me being able to see her by telemedicine, I was able to see her right away. And I got her right into the fertility specialist, which was good because she was at the time in her cycle that she would need to initiate to preserve her ovarian, to preserve eggs and embryos to later achieve, because she wanted to have a third child. So to later achieve pregnancy, it was important, that timeliness. And so, I haven't laid my hands on her yet, which I will do within the next week before she initiates chemotherapy. But that way I was able to coordinate, get her staging done, get an MRI of her breast because her disease is extensive within her breast, and have her, I think most importantly, undergo fertility preservation. So then she can go on to have a third child like she wants to.
All right, great. And would you consider COVID-19 testing as well? With every single patient comes with the...
Well, no. So I won't, we've had, you might have heard, we've had an issue in the United States with testing. So testing is not readily available for everyone. And so there aren't very many places where we're routinely testing everyone. I would say the exception to that is when we bring patients in the hospital for surgical procedures. Those patients are all going through testing. But, she won't need a surgical procedure probably for 5 or 6 months. And so, we'll see what the world looks like then.
All right. Why I'm asking, because I've been through one of the JAMA publication, JAMA Oncology paper. It was published from our colleague here, Dr. Hamid Shamsi, who is a medical oncologist in the UAE here. He was just screened like 85 patients with cancer who comes to his clinic during like a couple of months ago, during April and beginning of May. And amazingly, surprisingly, 10% of those, the test comes positive.
Wow.
Yes, and it was published straight away in JAMA Oncology. I didn't know if you have access to that.
I do. I didn't see that article, but yes, I do.
Okay. So they just randomly screen, or every single patient comes to his clinic with cancer diagnosis, even during follow-up period, not newly diagnosed. And 10% is Quite big number, right?
It's a big number.
Dr. Fatma, you want to comment?
Dr. Maryam?
Dr. Maryam, sorry.
Yeah,
Dr. Maryam.
Fatma
I'm sorry.
Fatma is my mother.
Okay, Dr. Maryam, sorry.
Yeah, I like this article so much, and Dr. Hamid Shamsi and Dr. Subair Rawi, they are pioneers when it comes to anything related to oncology, especially with COVID and pandemic, and specifically going back to the positives. And I don't want to go in a very specific details about the result. We had a very healthy discussion because, as you know, positive COVID doesn't mean that you have a COVID. There is another sequences where we need to go again through those 10%, because when I saw the article and I saw 10%, it was alarming for me, you know, which means it needs to be integrated as soon as possible to protocol for any patient. So that it was an eye-opener for all of us, and I was so happy to see such a paper from United Arab Emirates when it comes to COVID. Here I would like to ask Dr. Debra, what about the confidentiality? Some of our patients, especially with telemedicine, where we are so far using Zoom and using those different applications, which is accessible by everybody. And when it's come to the patient privacy information, and sometimes even, I cannot say clinical examination, but at least some of those worry signs where female can see on herself. So some of the patients, they had a huge debate on the confidentiality of the data, as well as discussing such subject, because majority, as you know, in United Arab Emirates and in this part of the world, we don't like to tell everybody that we have a cancer. So they were so much worried about that. I don't know how you dealt with that, Dr. Debra.
Well, we recommend a HIPAA compliant platform. So legally we're permitted to use anything that's private, even if it's not HIPAA compliant, but we're only using a HIPAA compliant platform. So it's the same standard of privacy as any of the other medical data. Zoom has a regular format, and then Zoom also has Zoom Medical, which is a HIPAA compliant platform.
Yeah.
We use VC, but there's also DoxyMe, which is easy for patients to use, that are good HIPAA compliant platforms. So there are good HIPAA compliant platforms to use. Again, there's a lot of reasons I prefer the VC platform, but there are many to use, and I think by using a HIPAA compliant platform, it keeps that easy. You do need to think about other things, though, to your point, because it's a different environment. You can't control that you're in one room with your patient. And so you may be interacting with them. I've interacted with patients in their homes. I've interacted with patients at their place of work. I've interacted with patients in their car. And so, you know, I don't control it. You know, we set the meeting, I reach out to them and they join in, but you can imagine that some places are more private than others. And so we do give them guidance for them to call in a private location. And most patients choose to do that, but it can be variable. But I would strongly recommend you use a HIPAA compliant platform. You know, I think there's all sorts of challenges with using a non-HIPAA compliant platform. It's not a good idea. So I think it makes patients feel more secure.
And I do, Dr. Debra, value a lot your point when it comes to training the physician how to use the telemedicine. And the same is applicable for the patient as well. So we need to have that approach to our patient.
Yeah, that's what I was saying as we approached launching telemedicine more broadly, that it was important to get our marketing team on board so they could put information about how to use the platform on our website for patients to use. And then our schedulers proactively reach out to patients before their visit when they schedule them so they can download the application and they know how to use it, because it is really important that they do that. And some platforms are easier than others, I think. You know, but patients need that that training too, especially some of our older patients.
Yeah. And I don't know, Dr. Debra, how much you know about the demography in United Arab Emirates. We have too many languages. We have Indian, we have Filipino. And again, when it's come to cancer and disease, everybody would like to use their mother language. And in that case, again, there is another barrier where we need to consider. And that, I believe, an opportunity for our colleague in telemedicine to tackle all these challenges as soon as possible. And as Dr. Sausan said earlier, COVID-19 is an accelerator for our colleague to come up with all those solutions.
Yeah, so I'll say the platform that we use, VC, you do have the ability to have another individual on audio. And so that's been helpful. Even in Texas, it's not the same as the UAE, obviously, but we have a large Hispanic population that speaks Spanish as their first language. We also have a large Vietnamese population. And so, so frequently we need translators, and the translators are available. The other thing is we are able to bring in a scribe. And so they remote in, you know, you have them in an audio connect to visit. And so some of our doctors use scribes instead of dictating their visits. And so that way they're able to bring in the scribes as well.
Sorry, Dr. Rial, final point to Dr. Dibra. What about the clinical research in cancer? As it was reported, more than 200 clinical trials were on hold in the past 3 months. How is the situation in your center?
It's been very difficult to accrue because I feel like everything that we do, research or not research, takes much longer. You know, we're all masking for patients. We all screen patients. We're having to explain to them not to have visitors, how to do telemedicine. We have our schedulers calling them instead of meeting with them in our office. Everything takes longer, but we still have clinical trials open. I still have patients on clinical trials. In fact, we opened 2 breast cancer trials yesterday. So I'm excited about that. But we are doing a lot of our normal functions that we do in person over a virtual platform. So things like CRO monitoring, remote site monitoring, that's occurring through a bimodal platform. Some of the documentation is done remotely. And so it's changed quite a bit. I will say, though, it's not been a hard stop on research for us, though it has been for many. But it is harder because if every visit that I have with patients, I spend another 10 minutes talking about coronavirus management. So that takes time. All of our new processes take time. And so it's harder for clinicians to be willing to spend that extra time required to accrue patients to research. But, you know, we're still going, not as strong as we were before coronavirus, but we're still going.
Excellent.
Absolutely.
Thank you, Dr. Dibra.
Thank you very much. Thank you, Dr. Mariam and Dr. Dibra. I just would like to remind the audience if there are any questions for the panel. We would love to. We'll do our best to answer. So up until now, we don't have any questions.
Or even comment, Dr. Rial, because maybe we can have shared experience from the floor. Maybe some of the attendees can share their experience as well.
Absolutely.
With telemedicine. So they can share through chat, Dr. Rial, or how is it work? Does it work?
Yes. One is asking, Pierre is asking, how can we discuss the applications for the technology to telemedicine? Dr. Pierre. So, would you like to comment, Dr. Debra?
I think the technology has improved tremendously. You know, it is useful to have broadband access. I would say that VC, we use almost exclusively the VC platform, and that technology I think is such a nice patient interface. They do have to download the app, so that's one step they have to do. But I think once they're on the app and being seen, it's a very nice interface for patients. I'll say that the other large, so there's another big cancer practice in the United States, Florida Cancer Specialists, and they're about half our size, and they're using the DoxyMe platform, and that technology has been useful. But as I mentioned, I think VC is a wonderful interface. DoxyMe is a good interface. Zoom Medical is a useful interface. And then in some of our regions where it's more challenging, they have to even do things like pick up the phone, where broadband access is more limited.
Yeah.
I apologize, I have to leave you now to go to another meeting, but it was so lovely to be on with you. Thank you so much for your comments.
Thank you very much. Thank you. Thank you for having us, Dr. Debra. Thank you very much. Svetlana, do we have still time to? One more question, I think, for Dr. Sousan will go for that. What about the screening programs?
What was the problem? Is my team asked that question. That's the problem. Which means how smart they are. They're very smart. Well, there is definitely room for telemedicine when it comes to screening, because you can have that introductory. And I think this is what maybe Dr. Pat was saying, is that introductory, where is that clinical history, you can have it, you can ask one of the colleague, maybe the nurses or the health educator, to actually have that with the lady. And then for the actual clinical examination and the actual mammogram screening, let's say, for example, if we take the breast cancer screening, then that has to happen. As you said, Dr. Yeltsin, there's something that we need to go to the hospital to. Now, I think it's interesting because we have been using telemedicine in our initiative in Caravan for a while now, I think for a year, where we actually are using, using telemedicine in reading the mammograms, X-rays. So the mammograms is being actually shared on a global platform where we have other doctors across the globe giving us first and second reading. And I think that is an interesting, has been an interesting experience for us, and made the actual reporting time for us very, very, very much shorter. I would also like to share one more point, and I would thank the panel for their time and the audience as well, is the fact that many of the actual patients who went through that experience of being at the comfort of their home and yet being able to have that one-on-one discussion with their doctor, either on a phone conversation or a video teleconferencing like what you're doing right now, I think that created a lot of bonding as well with the patient-doctor relationship. And to be honest, I don't think patient would like to go back to normal hospital visits anymore. Hospitals in general are I'm a doctor, I'm a physician and an MD certified doctor. But I think it's a very depressing environment, because that label of me going to a hospital means that I'm sick and I'm not feeling well. Where most of the patients, especially in the post follow-up phase, they're actually really feeling well, and they actually want to feel the normality of going back to that, that normal life. And I think this is the new positive outcome. You know how they say there is a silver lining somewhere. I think in COVID-19 thing, this is the silver lining. I think I would presume that in the future we'll see lots of patients pushing for having more teleclinics with their doctors, especially if they're not in critical case, more than actually going to the hospital.
That's right.
Thank you, Dr. Yab.
I agree. Just one last question. I will take actually two. One to Dr. Mariam. Is telehealth implemented in genetic settings?
Oh, in genetics, we are surviving on telemedicine, and that's why, for example, we in Sheikh Zayed Genetic Research Center, although we are in Dubai in Jumeirah, but you can see we have a very strong collaboration on the level of a very detailed research, and with all the infrastructure of telemedicine, we are able to share a very big data with a very high level of confidentiality. And when it's come to genetic, I believe COVID-19 had a great impact to identify the ethnicity and how it does matter. And again, it reflected another area where most of us as a physician, sometimes we underestimate that not all of us can respond the same when it's come to an infection, especially because we had developed a very fair experience when it's come to non-communicable like diabetes and hypertension and so on. But in an infectious, most of the time it was in a textbook which we used to read. But right now with this pandemic, we do understand, and we saw the proof that if a patient in United Arab Emirates will be infected with COVID-19, it's not necessarily to go to the same course where the same person with the same age group and sex had in Europe or in United States. And that itself brought the concept of genotype clinical decision, not only in communicable diseases, communicable. And again, genetics, right now we know very soon, and especially with COVID-19, now before I diagnose any case, I need to even search for their genotype. And that itself play a huge role in me showing or discussing the prognosis of such illnesses on this patient according to his genotype, ethnicity, and according to his DNA or his mitochondrial and his cell age, which we know right now, it's not anymore a blood test to say if you are healthy or not. It goes beyond that. It is the cell age where we measure it with a specific way in the lab to know exactly if you are 44 years old and your cell acting as 16 or acting as a 60. And that itself has a huge impact on you deciding which medication he should have. And that itself, Dr. Riyad, I'm sure with Dr. Sousan, it was clear again in psychiatry. As Dr. Sousan mentioned earlier, with the pandemic, the psychological impact was hugely shown in different aspects, and even those people who didn't have the COVID-19. Right now, we know that we as a physician and as a psychiatrist, our colleague, they cannot even prescribe the medication before examining the genotype and the specific type of the enzyme in their liver, how it will act with this medication. So again, genetic coming in the front line when it's come to communicable or non-communicable disease. With telemedicine, it was one of the tools where we accelerated the whole advantage and progress in genetics and in epigenetics as well.
Excellent. I can't agree more. I think what you say, Dr. Mariam, is totally right. Even if we're witnessed now the era of personalized medicine, individualization of medicine, and that's based on genetic part. Without the genotyping, we cannot say this will take treatment A and this B and this C. So that's very important, yes. One last bit here is I've seen one question regarding digital clinical trials. In the context of oncology, I would say that even in Europe or in the Northern America, we haven't heard of such digital clinical trials established. So we'll be there if we have, but even the translational cancer research now, we stopped everything for the COVID-19 and we start working on COVID-19 projects. So I believe we're done. I don't see any more questions here. In the Svetlana, are we done with time, or we still have some more time? Okay, so we're done with time. It was really a very fruitful discussion. Thank you, Dr. Mariam, for joining us today.
Thank you.
It was really a pleasure for us.
شكرا جزيلا دكتور رياض.
Thank you.